Welcome back to the Deep Dive, where we take your source material and distill it into something truly insightful, giving you that aha moment without the information overload. Today, we're embarking on a fascinating and really crucial journey into the world of fungi and the powerful agents we use to combat them. Our mission is to truly master this vital information, to understand it like the elite professionals in this field do.
Indeed. Fungi are absolutely everywhere, and while, many are harmless, a significant number pose quite serious threats to human health. We're going to thoroughly unpack the current landscape of antifungal pharmacotherapy. We're talking understanding not just what these drugs are, but how they work at a fundamental level, why their development is so challenging, where the cutting edge of treatment lies. We'll delve into the specific classes of drugs, their mechanisms, their diverse uses, and that delicate balance between efficacy and, well, toxicity. Think of this as your shortcut to deeply understanding this complex but absolutely vital realm of medicine.
Okay, let's unpack this then. You've provided us with a real wealth of information here, everything from the very nature of the fungal kingdom itself to the intricate details of drug formulations and their interactions. We'll be looking at everything, the long-standing gold standard drugs, the newest therapies, exploring how they tackle these really persistent pathogens. Get ready to feel truly well-informed on a topic that touches modern medicine perhaps more profoundly than you might realize.
The fungal kingdom, a silent threat emerges.
So before we even talk about fighting fungi, let's get a handle on what we're actually up against. We're talking about a massive kingdom here, right? Far more than just, the mushrooms we see.
Absolutely. The kingdom fungi is incredibly diverse and vast. While we currently know of around 200,000 species, some estimates suggest the total number could be well over 1 million, maybe even more. This kingdom encompasses everything from microscopic yeasts and molds to the familiar mushrooms and even less-known forms like smuts. This immense diversity, you can probably imagine, hints at the profound challenge in developing broad-spectrum treatments. Imagine trying to create a single tool that could fix everything in a million-item toolbox. It's almost impossible.
Oh, wow, okay, 1 million species.
Yeah.
And out of that huge number, how many are actually problematic for humans? Is it a large percentage?
Thankfully, no. It's a relatively small fraction that directly cause human disease. Only about 400 fungal species are known to cause disease in animals, and even fewer than that lead to human infections. However, despite this relatively small number, the impact is disproportionately large. These specific fungal infections, they're associated with significant morbidity. That means they cause a lot of illness and suffering, and sadly, also substantial mortality. So it's not really about the sheer number of species that are dangerous, but the severity of the danger posed by those few that are truly pathogenic.
Right, the impact is huge. And here's where it gets really interesting for modern medicine. Why has this become a bigger problem more recently? What's driving the rise in these life-threatening infections?
Well, the incidence of life-threatening fungal infections has seen a concerning increase in recent decades, and this is a critical trend to understand. This rise is primarily driven by the growing populations of immunocompromised patients.
Okay, so people whose immune systems aren't working at full strength.
Exactly. Think about individuals receiving organ transplants, both solid organ and hematologic, like bone marrow transplants, or those undergoing aggressive cancer chemotherapy. Also, patients on immunosuppressive medications for various autoimmune conditions, and certainly those with HIV/AIDS, they're all highly vulnerable. These medical advancements, while life-saving in many ways, they unintentionally create this new landscape where fungal pathogens can thrive, because the patient's own immune system simply can't mount an effective defense. And this shift in patient demographics has profoundly elevated the importance of effective antifungal agents in modern medicine.
So we need these drugs more than ever. But developing them sounds like a huge challenge. You mentioned fungi are eukaryotes like us. Why is it so difficult to find drugs that target them without harming human cells?
That's the fundamental difficulty right there. It lies in the biology of fungi themselves, unlike bacteria, which are prokaryotes, structurally very different from human cells.
Right, simpler in some ways.
Simpler, yes, and different enough to target easily. But fungi, they're eukaryotes, just like us. This close biological relationship means that many of our cellular processes, our basic machinery, are shared. That really limits the number of truly unique fungal targets that a drug can exploit.
So it's hard to find something specific only to the fungus.
Exactly. It's like trying to design a weapon that only harms one specific type of tree in a forest of very similar trees when all the trees are, genetically related. That's why designing selective antifungal drugs, those that effectively kill the fungus without causing significant toxicity to the human host, is an incredibly challenging undertaking.
But we have managed to find some vulnerabilities, haven't we? What are the key differences we've successfully exploited to create our current antifungal arsenal?
Precisely. Scientists and pharmaceutical researchers have been, quite clever in identifying and exploiting key differences in fungal biology. It takes real ingenuity. For example, fungi have unique membrane sterols, primarily ergosterol. Mammalian cells, our cells, use cholesterol instead. Right.
Oh, okay, a different building block for the membrane.
Exactly. And that difference has been a prime target for a whole class of drugs, as we'll see. Fungi also have the ability to deaminate cytosine. That's a metabolic pathway mammalian cells generally don't use in the same way. Another selective vulnerability. And crucially, fungi possess a unique cell wall. It contains components like glucans and chitin.
Things we just don't have.
Right, entirely absent in human cells. All of these distinct features have been successfully leveraged to produce relatively safe and effective antifungal agents. It demonstrates remarkable work in finding those fungal Achilles heels.
What's fascinating here, though, is that even with these breakthroughs, the fight isn't over. We've come a long way, but the problem persists, especially with these invasive infections.
That's absolutely right. Since the advent of Amphotericin B deoxycholate in the late 1950s, which truly was a landmark, a real turning point in treating systemic fungal infections, research has continuously sought safer and more effective alternatives. While Amphotericin B, as we'll discuss, still holds its ground as the gold standard for a wide range of severe infections, the unfortunate reality is that even with our current pharmacopoeia, mortality rates for invasive fungal disease remain unacceptably high. And this just underscores the ongoing need for deeper understanding, for continued innovation in this field. We need to keep pushing researchers to find new targets and develop even more precise therapies to address this persistent threat.
The gold standard and its evolution. Amphotericin B.
Okay, let's start with that gold standard you mentioned, Amphotericin B. For decades, it's been the go-to, the heavy hitter for serious fungal infections. What makes it so special? What are its fundamental properties that give it such power?
Amphotericin B is a truly remarkable drug. It's really a cornerstone of antifungal therapy. Chemically, it's known as an amphipathic polyene macrolide.
Okay, break that down for us. Amphipathic.
Amphipathic means it has both water-attracting hydrophilic and fat-attracting lipophilic parts. This dual nature is absolutely crucial to how it interacts with cell membranes. As a polyene, it has this distinctive structure with multiple double bonds that's key to its activity. And it's a macrolide, which refers to its large ring structure.
Yeah.
Now, its poor solubility in water has always been a major challenge, which is precisely why its various formulations are so important for clinical use.
So how does this complex molecule actually kill fungi? What's its unique mechanism of action that targets the fungus so effectively?
Well, its antifungal activity depends principally on its ability to bind to ergosterol in the fungal cell membrane. Remember, that's the sterol unique to fungi. For a long time, the prevailing thought, the classical model, was that amphotericin B formed discrete pores or channels in the membrane.
Like punching holes in it.
Exactly, essentially punching holes in the fungal cell, leading to leakage of vital contents, ions, small molecules, and ultimately cell death. It was envisioned almost like puncturing a balloon.
But you mentioned recent evidence suggests a different, maybe even more surprising idea. What's the updated understanding of how it works?
Yes, this is fascinating, and it's a great example of how science evolves even for drugs we've used for ages. More recent research, particularly from a significant 2014 study, suggests a different, maybe more nuanced model. Instead of forming discrete, static pores, amphotericin B appears to form these large aggregates.
Aggregates? Like clumps?
Kind of, yeah.
Yeah.
Large clumps that effectively sequester ergosterol from the lipid bilayers, much like a sponge.
A sponge. Interesting image.
It literally extracts the ergosterol out of the fungal membrane, pulling it away. This sponge mechanism fundamentally disrupts the membrane's structure and integrity, and that leads directly to fungal cell death. This updated model helps explain its incredible potency and really highlights the precision with which it targets that fungal-specific molecule, ergosterol.
That's an incredible image, a sponge literally pulling apart the fungal cell membrane. Now, the source material goes into great detail about different formulations of amphotericin B. Why are there so many, and what are the key differences clinicians, and indeed anyone wanting to master this, need to be aware of?
Right. The poor aqueous solubility and, importantly, the inherent significant toxicity of the original conventional amphotericin B, or CAMB, that really drove the development of alternative formulations. The goal was clear: improve safety, reduce those nasty side effects, and optimize drug delivery. So there are 4 commercially available forms we really need to unpack. CAMB, the original, ABCD, amphotericin B, colloidal dispersion, LAMB, liposomal amphotericin B, and ADLC, amphotericin B lipid complex. Let's just quickly compare them, focusing on the key distinctions. First, CAMB, conventional amphotericin B. This is the original, formulated with deoxycholated bile salt to allow IV infusion. It forms tiny particles in solution. A crucial practical detail here: standard IV filters, the ones designed to trap particles larger than 0.22 micrometers, can actually remove significant amounts of the drug. That impacts delivery.
So you might not be giving the intended dose?
Exactly. And also, adding electrolytes to infusion solutions can cause this colloid to precipitate, to crash out of the solution. Then there was ADTD, amphotericin B colloidal dispersion. This combined amphotericin B with cholesterol sulfate. It actually provided much lower blood levels in humans compared to CAMB. And clinically, studies found that patients receiving ABCD experienced significantly more chills and hypoxia compared to CAMB.
More side effects. That's not ideal.
Not at all. And perhaps because of this, ABCD is no longer commercially available in the U.S. Next, LAMB, liposomal amphotericin B. This is where amphotericin B is encapsulated within a small unilamellar liposomal vesicle, basically a tiny fat bubble. It's applied as a lyophilized powder and reconstituted with sterile water. The big advantage here is that blood levels following IV infusion are almost equivalent to CAMB. And because LAMB can often be given at higher doses due to better tolerance, it can even achieve blood levels that exceed those obtained with CAMB.
So similar effect, potentially better safety.
Generally, yes. And finally, ABLC, amphotericin B lipid complex. This is a complex of amphotericin B with 2 specific phospholipids. It's typically given at a standard dose, like 5 mg/kg, while it offers an alternative and is effective in a variety of mycoses. Blood levels of amphotericin B are notably lower with ABLC than with the same dose of CAMB, and there's a possible exception noted for its effectiveness in cryptococcal meningitis. So the key takeaway, the thing to really grasp when comparing these formulations, is their impact on toxicity and cost. All 3 lipid formulations, ABCD, when it's available, LAMB, and ADLC, significantly reduce the risk of acute kidney injury compared to CAMB. We're talking about a reduction of around 58%.
That's a huge improvement in patient safety. Kidney damage is a major worry with CAMB.
Absolutely. However, the specific lipid formulations have their own nuances. ADLC, for instance, has been observed to be somewhat more nephrotoxic than LAMB in high-risk patients. And when it comes to those infusion-related reactions, the fever, the chills, it's not a consistent improvement across the board. As I mentioned, ABCD actually caused more infusion reactions than CAMB. LAMB generally causes fewer initial infusion reactions than ABLC, but this can vary based on premedication and the individual patient. Generally, these reactions tend to decrease with subsequent infusions. It's a trade-off, though. The lipid formulations, while less toxic overall, are considerably more costly than CAB.
Right, cost is always a factor.
Always. And that limits their availability in many countries and dictates their more prudent use even in resource-rich areas. Interestingly, CAMB is actually better tolerated by premature neonates than by older children and adults, so it still keeps a relevant place in antifungal care in critical care nurseries.
That's a great overview of the formulations and the trade-offs. Now, what does this all mean for how the drug moves through the body? Let's talk about its ADME, absorption, distribution, metabolism, and excretion.
Okay, ADMA. For all amphotericin B formulations, absorption from the gut is negligible, minimal. This is a critical point to remember. For systemic use, for deep infections, intravenous delivery is absolutely indicated. You cannot take this orally and expect it to work systemically. Once it's in the plasma, over 90% of amphotericin B is bound to proteins. What's intriguing is that the pharmacokinetic properties differ significantly among the preparations, as you'd expect. But notably, conditions like kidney dysfunction, what we call azotemia, or liver failure, or even hemodialysis, they don't seem to have a measurable impact on the drug's plasma concentrations.
That's surprising, but useful clinically.
It is. It simplifies management somewhat in patients who often have these common comorbidities.
And where does it actually go in the body? Does it get into those hard-to-reach places like the brain or the eye?
This is a critical point, and yeah, it can be quite counterintuitive. While amphotericin B, especially CAMB, can reach pretty good concentrations in fluids, from inflamed pleura peritoneum, synovium joint fluid, and the aqueous humor of the eye. Its penetration into some key areas is surprisingly poor. Very little amphotericin B, regardless of its formulation, gets into the cerebrospinal fluid, CSF.
The fluid around the brain and spinal cord.
Exactly. Or into the vitreous humor, the main part of the eye, or normal amniotic fluid. This is particularly striking because despite this poor CSF penetration, amphotericin B, often combined with flucytosine, is still considered the treatment of choice for certain severe CNS fungal infections.
Like cryptococcal meningitis.
Like cryptococcal meningitis and coccidioides, meningoencephalitis. This really highlights something important. Either the drug is just so potent that even low concentrations work in sensitive tissues, or it emphasizes the critical importance of its combination with other drugs, like flucytosine, that do penetrate well. It's a real aha moment for understanding treatment strategies.
That truly is counterintuitive, but a crucial point. So, what kind of fungi does amphotericin B actually fight? What's its spectrum of activity? Why is it the gold standard?
Well, amphotericin B boasts a remarkably broad spectrum of useful clinical activity. It works against a wide range of pathogenic fungi. This includes various Candida species, Cryptococcus neoformans, Blastomyces dermatitis, Histoplasma capsulatum, Sporothrix schinki, Coccidioid species, Aspergillus species, and importantly, the agents of mucorales infections, also known as mucormycosis, and many others. Beyond fungi, it even has limited activity against certain protozoa like Leishmania species and Naegleria fowleri.
The brain-eating amoeba.
That's the one. But importantly, it has no antibacterial activity whatsoever. This broad coverage against so many different serious fungi is a major reason it earned that gold standard title.
With such a broad spectrum and powerful action, is resistance a big problem for amphotericin B in clinical practice?
It's an interesting situation. While resistance is certainly observed, and we need to be aware of it, clinical resistance to amphotericin B among fungal species is, historically, exceedingly rare. This is largely because amphotericin B is fungicidal. It actively kills fungal cells, rather than just inhibiting their growth like some other agents. And mutations that affect its critical membrane target, ergosterol, are often associated with significant fitness costs for the fungus.
Meaning the resistant fungus might be weaker?
Exactly. It makes such resistant strains less viable in a competitive environment. If a fungus changes its ergosterol enough to evade the drug, it often becomes too weak to survive effectively in the host.
But there must be exceptions. Some fungi that have figured it out.
Yes, there are notable exceptions, and these are clinically very important to know. Isolates of Candida lusitaniae are frequently resistant. That's one to watch out for. Similarly, Aspergillus terreus and Aspergillus nigulans appear to be less susceptible than other Aspergillus species. And a significant concerning exception is Candida auris. This is an emerging global threat, and nearly one-third of clinical isolates are considered resistant to amphotericin B based on CDC breakpoints.
Wow, 1/3. It's worrying.
It is. It really highlights the dynamic nature of fungal evolution and resistance, even against our most powerful, long-standing drugs.
Okay. Given its potency and broad spectrum, despite the resistance concerns, where is amphotericin B used most effectively in therapy today? What are its prime indications?
Intravenous administration of amphotericin B is the treatment of choice for invasive mucormycosis. This is a highly aggressive and often fatal fungal infection, and Ampho-B is really critical here. Furthermore, in combination with 5-flucytosine, it remains the gold standard for the induction treatment of cryptococcal meningitis, that initial intensive phase of treatment. It's also indicated for the treatment of severe or rapidly progressive forms of other deep fungal infections, think histoplasmosis, blastomycosis, coccidioidomycosis, and it serves as a crucial salvage therapy. That means it's used for patients who haven't responded to azole treatments for conditions like invasive aspergillosis or certain other difficult infections like fusariosis.
So when other drugs aren't working?
Exactly. It can even be used empirically, meaning based on strong suspicion before a specific fungus is identified in selected patients with profound neutropenia, like cancer patients who have persistent fever despite broad-spectrum antibacterial agents. However, it's worth noting that more recently developed azoles and echinocandins are generally preferred for that specific empirical use, mainly due to their reduced toxicity profiles compared to CAMB.
You mentioned some interesting alternative ways to administer it earlier, beyond just IV for very specific situations. Can you elaborate on those?
Indeed. While IV is the primary systemic route, there are some niche uses. For conditions like candida esophagitis, which is often quite superficial, much lower oral doses of amphotericin B can sometimes be effective due to local action in the esophagus, not systemic absorption. And for patients with meningitis caused by coccidioides, intrathecal infusion of CA and B can be useful.
Injecting it directly into the spinal fluid.
Precisely. Directly into the CSF of the lumbar spine, or sometimes other sites like the cisterna magna or a lateral cerebral ventricle. This direct delivery bypasses that core blood-brain barrier penetration we discussed. It involves injecting small doses, typically 1 to 3 times weekly. While this local administration can cause common reactions like fever and headache, sometimes reduced by co-administering hydrocortisone, intrathetically the benefit in severe, otherwise untreatable cases sometimes outweighs the risk. But its general use intrathecally can't be broadly recommended due to a lack of extensive clinical data. Beyond CNS infections, local injections into a joint or into peritoneal dialysate fluid can be used to treat localized infections there, though it can cause irritation and pain. And even intraocular injection directly into the eye after surgery has been used to treat fungal endophthalmitis. So it shows some versatility for targeted local delivery when needed.
Okay, this is clearly a powerful drug, but it really sounds like it comes with some serious side effects. What are the major adverse events we need to be acutely aware of when using amphotericin B, especially the conventional form?
You're absolutely right. Its efficacy comes at a price. There's a significant profile of adverse effects, particularly with the conventional formulation, CAMB. It's often referred to as amphoterrible by clinicians for a good reason. Let's detail these major adverse events, because understanding these is key to using the drug safely. First, acute infusion reactions. The most common acute reactions are fever and chills. These can be quite dramatic for the patient, sometimes called shake and bake. These reactions are believed to be due to the drug's ability to induce a pro-inflammatory response in cells of the innate immune system.
So it triggers the immune system directly.
It seems so. These infusion reactions are most prominent with ABCD when used, while LA and B administration appears less commonly associated with them. Patients can also experience tachypnea, rapid breathing, respiratory stridor, a high-pitched breath sound, or modest hypotension, low blood pressure. Thankfully, frank bronchospasm and anaphylaxis are rare. Patients with pre-existing heart or lung disease might tolerate the metabolic demands of this reaction poorly, potentially developing more severe hypoxia or hypotension. The good news is these reactions typically end spontaneously within 30 to 45 minutes. Treatment with meperidine can sometimes shorten them. And importantly, pre-medication with oral acetaminophen or ibuprofen or intravenous hydrocortisone can decrease these reactions, and they tend to abate, to lessen, with subsequent infusions as the body adjusts.
So the first dose is often the worst.
Often, yes. Second, and perhaps most famously, nephrotoxicity, kidney toxicity. This is the most well-known and feared side effect, and a major limiting factor for conventional amphotericin B. Azotemia, indicating kidney dysfunction, occurs in a remarkable 80% of patients who receive CA&V for deep mycosis.
80%? That's incredibly high.
It is. And as we discussed, the lipid formulations are significantly less nephrotoxic, which is why they are often preferred despite the cost. This toxicity is dose-dependent and usually transient, reversible. However, it's made worse by concurrent therapy with other kidney toxic agents like aminoglycoside antibiotics or cyclosporine. While permanent histological changes in the kidney tubules can occur even with short courses of CA and B, permanent functional impairment is uncommon in adults with normal kidneys beforehand, unless the total cumulative dose gets very high, exceeding 3 to 4 grams. Other renal issues include renal tubular acidosis and renal wasting of potassium, K+, and magnesium, Mg2+. These can be seen during and for several weeks after therapy.
So patients need electrolyte monitoring and replacement.
Frequently. About 1/3 of patients on prolonged therapy will require supplemental potassium. Interestingly, saline loading, giving a liter of normal saline intravenously on the day CA&B is given, has been shown to decrease nephrotoxicity, even in patients who aren't dehydrated. Third, hematological effects. Hypochromic normocytic anemia, that's a type of anemia where red blood cells are paler and normal-sized, is a common occurrence during CA&B treatment. This anemia is less frequent with the lipid formulations and typically isn't seen during the first 2 weeks of therapy. It's thought to be due to decreased production of erythropoietin, the hormone that stimulates red blood cell production. It often responds to administration of recombinant erythropoietin. And finally, other common effects. Patients frequently report headache, nausea, vomiting, malaise, just feeling generally unwell, weight loss, and phlebitis inflammation of the vein at peripheral infusion sites. This can make maintaining IV access challenging over prolonged courses. And a specific complication we mentioned with intrathecal administration of CMB is arachnoiditis, and inflammation of the arachnoid membrane surrounding the brain and spinal cord.
Targeting fungal replication, flucytosine.
Okay, moving on from the complexities of amphotericin B, let's look at flucytosine. This is a drug with a more limited but very specific and important role, often used in combination therapy. What is it chemically speaking, and how does it manage to selectively harm fungi?
Right. Flucytosine, which is also known as 5-fluorocytosine, or 5-FC, is a fluorinated pyrimidine. Its structure is actually closely related to fluorosil, or 5-FU, which is a potent antimetabolite drug used in cancer chemotherapy.
Ah, so related to a chemo drug.
Exactly. And that connection is key to understanding its powerful yet specific mechanism of action. It employs a really elegant Trojan horse strategy for selective toxicity. The antifungal activity of flucytosine relies entirely on a critical biochemical difference between fungi and human cells. All susceptible fungi possess the enzyme cytosine deaminase.
An enzyme we don't have.
Generally, no, not in the same way or amount. This fungal enzyme is capable of chemically modifying flucytosine, deaminating it directly into 5-fluorosil, 5-FU, but critically, this happens inside the fungal cell. Once that toxic 5-FU is formed within the fungus, it's further metabolized. It can either be incorporated into fungal RNA, disrupting RNA function, or it can be converted into another molecule, 5-FDUMP. And 5-FDUMP is a potent inhibitor of thymidylate synthase, an enzyme absolutely crucial for DNA synthesis. So by inhibiting this, it ultimately blocks fungal DNA synthesis. The selective action, the reason it's relatively safe for humans, is precisely because mammalian cells generally lack sufficient cytosine deaminase activity. This prevents that critical conversion of flucytosine to toxic 5-FU in our own cells.
So the drug only becomes toxic inside the fungus itself.
Yeah, it's brilliant. It's a very clever mechanism, leveraging a specific fungal enzyme.
That is brilliant. So how does the body handle flucytosine? Let's talk about its absorption, distribution, metabolism, and excretion, the ADME profile.
Okay, ADME for flucytosine. It has excellent bioavailability when administered orally. It's absorbed rapidly and almost completely from the gastrointestinal tract.
That's a big plus, being effective orally.
It is a significant advantage for patient convenience. It distributes widely throughout the body with a volume of distribution that approximates total body water, and it's minimally bound to plasma proteins, meaning a large proportion of the drug is free and active. Importantly, for fungal infections in the brain, the flucytosine concentration in cerebrospinal fluid, CSF, is quite high. It reaches about 65% to 90% of the simultaneous values found in the plasma.
So good penetration into the CNS.
Very good penetration, making it a valuable partner for drugs like Amphotericin B in treating meningitis. The drug also appears to penetrate into the aqueous humor of the eye. Approximately 80% of a given dose is excreted unchanged in the urine. This leads to very high concentrations in the urine, which could be useful for fungal UTIs, though that's not its main use. The drug's half-life is relatively short, about 3 to 6 hours in individuals with normal kidney function. But, and this is critical, this can extend dramatically to as long as 200 hours in patients with renal failure.
Wow, a huge difference.
Massive. Therefore, dosage reduction is absolutely necessary for patients with decreased kidney function. And ideally, plasma concentration should be measured periodically to ensure they remain within the therapeutic range, typically 50 to 100 micrograms per ml, to maximize efficacy and minimize toxicity. Furthermore, flucytosine is effectively cleared by hemodialysis, so patients undergoing dialysis should receive a single dose after their dialysis session.
It sounds like it's quite active, penetrating well, but the source material says its usefulness as a single agent is really limited by resistance. Why is that? Why can't we just use it on its own more often?
That's correct. Flucytosine is currently used primarily as an adjunctive agent. That means it's given alongside other antifungals, most notably with Amphotericin B, especially in that initial induction phase of therapy for cryptococcal meningoencephalitis. While it shows good activity in the lab against a number of pathogens, the rapid emergence of resistance significantly limits its usefulness as a single-agent therapy. If used alone, the fungus can quickly develop ways around its mechanism.
So resistance often develops during treatment with this drug if it's used alone.
Yes, exactly. Secondary resistance, meaning resistance that arises during therapy, is a major cause of treatment failure when flucytosine is used alone for infections like cryptococcosis and candidiasis. The mechanisms for this resistance are quite well understood. Fungi can develop resistance by losing the permease necessary for cytosine transport into the cell, basically. They shut the door so the drug can't even get inside. Alternatively, they can have decreased activity of either UPRase or that key enzyme cytosine deaminase. These are the enzymes crucial for converting flucytosine into its active toxic forms inside the fungal cell.
So they either block entry or block activation.
Precisely. For example, in Candida albicans, even a single nucleotide change in the gene encoding UPRase can lead to resistance. This highlights how relatively simple genetic changes can undermine a drug's mechanism, effectively bypassing that Trojan horse entry or activation.
Given these limitations, where is flucytosine primarily used therapeutically today? What's its main role?
Flucytosine is given orally, typically 50 to 150 mg/l per day, divided into 4 doses at 6-hour intervals. And again, the dosage must be adjusted for decreased renal function. It is used almost exclusively in combination with Amphotericin B for the treatment of cryptococcal meningitis. This combination, compared with Amphotericin B alone, has been clearly shown to significantly improve survival among patients with cryptococcal meningitis. It's a cornerstone of treatment.
So adding flucytosine makes a real difference in survival.
A significant difference. Based on this evidence, the addition of flucytosine to Amphotericin B is currently considered the gold standard for cryptococcal meningitis induction treatment. Furthermore, recent studies, which are quite important, have indicated that a 2-week course of fluconazole plus flucytosine can be as effective for cryptococcal meningitis induction therapy as a 1-week course of Amphotericin B plus flucytosine.
An all-oral option.
Exactly. This fluconazole-flucytosine combination offers an all-oral regimen, making it much easier to administer, especially in resource-limited regions with a high burden of this disease, where 4V administration and monitoring for Amphotericin B can be very challenging. However, the main limitation to its broad implementation in these areas is often the expense and, frankly, the poor availability of flucytosine itself.
And what about the downsides? What are the adverse effects of flucytosine that patients and clinicians need to be vigilant about?
The most significant adverse effect of flucytosine is bone marrow depression, or myelosuppression. This can lead to leukopenia, a low white blood cell count, and thrombocytopenia, a low platelet count.
Affecting infection fighting and blood clotting.
Exactly, directly impacting the body's ability to fight infection and clot blood. Patients are more susceptible to this if they have an underlying hematological disorder, are undergoing treatment with radiation or other drugs that injure the bone marrow, or have a history of such treatments. Other reported side effects include rash, nausea, vomiting, diarrhea, and occasionally severe enterocolitis, which is inflammation of the intestines. In about 5% of patients, plasma levels of hepatic enzymes can be elevated, but this effect typically reverses once therapy is stopped. Toxicity seems to be more frequent in patients with AIDS or azotemia, kidney dysfunction, including those concurrently receiving Amphotericin B, which also affects the kidneys. And toxicity is definitely more likely when plasma drug concentrations exceed that upper therapeutic limit of 100 micrograms per ml. This is why monitoring drug levels, when possible, is so important. Interestingly, some of this toxicity may actually arise not from the flucytosine itself, but from its conversion to the chemotherapy drug 5-FU by the microbial flora, the bacteria, in the patient's own intestinal tract. That 5-FU can then be absorbed systemically.
Wow, so your own gut bacteria could contribute to the side effects.
It's a fascinating possibility, yeah.
The azole family, versatile ergosterol inhibitors.
Okay, now let's explore the large and very important family of azole antifungals. This group seems to have a really broad reach and is incredibly versatile in how it's used, doesn't it?
Indeed, the azole antifungals represent a real cornerstone of modern antifungal therapy. They are chemically divided into 2 broad classes, the imidazoles and the triazoles. The source lists many examples available in the U.S., including imidazoles like clotrimazole, Fluconazole, and ketoconazole, which we often see topically, and the triazoles, such as Echinocandins, Fluconazole, Voriconazole, Polyenes, and Griseofulvin, which are crucial systemically. While we'll touch on their topical uses later, their systemic applications are absolutely crucial for treating deep-seated invasive fungal infections.
What's the central mechanism of action for this entire group of drugs? How do they, as I said earlier, sort of gum up the works of fungal membrane production?
Right. The primary effect of both imidazoles and triazoles on fungi is the inhibition of a specific enzyme called 14-estrol demethylase. This is a cytochrome P450, or CYP enzyme, and it's the product of the fungal gene ERG11. It's a critical enzyme in the pathway that fungi use to synthesize ergosterol.
Ergosterol, again, that key fungal component.
Exactly, that unique sterol in the fungal cell membrane. By inhibiting this demethylase enzyme, azoles impair the biosynthesis of ergosterol. This leads to the depletion of ergosterol in the membrane and, just as importantly, the accumulation of toxic precursor products inside the cell. specifically a molecule called 14-methyl-3,6-diol. These toxic methylsterols disrupt the close packing of the phospholipids within the membrane and impair the functions of various membrane-bound enzyme systems, like nutrient transporters. This ultimately leads to fungal growth arrest. It's generally considered a fungistatic effect.
Meaning they stop growth but don't necessarily kill the fungus outright.
Correct, in most cases. They inhibit growth and replication, rather than actively killing the fungal cells like Amphotericin B does. Some azoles can directly increase membrane permeability at very high concentrations, but that's likely only achieved with topical application.
So, with that mechanism, what's their spectrum of activity? Which fungi are they generally effective against?
As a group, azoles have clinically useful activity against a wide array of fungi. This includes important pathogens like various Candida species, C. albicans, C. tropicalis, C. parapsilosis, Cryptococcus neoformans, the dimorphic fungi like blastomyces, dermatitis, Histoplasma capsulatum, Coccidioides species, and the common ringworm fungi, the dermatophytes. Some species like Aspergillus species, Cetosporium epiospermum, Fusarium, and Sporothrix kenki show intermediate susceptibility, meaning azoles might work, but perhaps less reliably or requiring higher doses. However, there are definite limitations. Candida glabrata often exhibits reduced susceptibility to azoles, and Candida krusei, along with the agents of mucormycosis, are generally considered more resistant.
So not effective against everything.
Definitely not. Although it's important to note, as we'll discuss, two of the newer triazoles, posaconazole and ixvuconazole, do show a modestly improved spectrum of activity in vitro against the agents of mucormycosis, offering some potential there.
And what about resistance to azoles? You mentioned some species are intrinsically less susceptible, but is acquired resistance a growing concern in clinical practice like we see with antibiotics?
Yes, absolutely. Azole resistance is a significant and increasingly described clinical problem, and it's a major challenge in managing fungal infections today. For instance, Candida glabrata and Candida krusei, as I mentioned, are considered intrinsically resistant or at least much less susceptible to fluconazole. Even more concerning is Candida auris. A staggering 90% of C. auris isolates are resistant to fluconazole based on tentative breakpoints proposed by the CDC.
90%. That's huge.
It's incredibly concerning. In Candida albicans and also in Aspergillus fumigatus, azole resistance can arise from several different mechanisms, making it complex. One involves the accumulation of mutations in ERG11, the gene encoding the azole target enzyme, 14-asteryl demethylase. These mutations make the target enzyme less sensitive to the drug.
So the drug doesn't bind as well.
Exactly. Another very common mechanism is increased azole efflux from the fungal cell. This is due to the overexpression of specific drug transporters pumps, essentially either ABC transporters or major facilitator superfamily transporters. These pumps efficiently expel the drug from the fungal cell before it can reach high enough concentrations to act.
Pumping the drug out as fast as it comes in.
Pretty much. This overexpression is often triggered by activating mutations in the genes that regulate these transporter pumps. A third mechanism involves mutations in a different gene in the pathway, ERG3. Such mutations prevent the formation of that toxic byproduct we mentioned earlier. The fungus finds a way to survive even with the pathway partially blocked. Additionally, just increased production of the target enzyme itself due to overexpression of the ERG11 gene can also contribute to resistance. Resistance has also been increasingly described in Aspergillus fumigatus isolates using similar mechanism target site mutations, increased efflux. And finally, in cryptococcal meningitis, patients treated with fluconazole monotherapy sometimes relapse, and their isolates often show decreased fluconazole susceptibility, which has been linked to changes in chromosome number, something called aneuploidy.
Wow, so fungi have many ways to fight back against azoles.
They are remarkably adaptable.
Given that these drugs interact with those CYP enzymes in the liver, I imagine there are a lot of potential drug interactions to watch out for. This seems like a critical point for safe and effective therapy, maybe even more so than with other antifungals.
This is absolutely a crucial point for clinical practice, and yes, it's arguably one of the biggest challenges, specifically with the azole class of antifungals. The azoles interact extensively with hepatic cytochrome P450 CYP enzymes. They act both as substrates, meaning they are metabolized, broken down by these enzymes, and as inhibitors, meaning they can slow down or stop these enzymes from metabolizing other drugs.
A double whammy, potentially.
Exactly. This creates a myriad of possibilities for interactions with many other co-administered medications that also use these CYP pathways. As a result, alloles can significantly elevate plasma levels of some other drugs, potentially leading to increased toxicity of that co-administered drug. The source provides tables listing many examples. Conversely, other co-administered drugs, particularly drugs that induce or speed up CYP enzymes, can decrease the plasma concentrations of the azole antifungal agents, potentially rendering the antifungal less effective or even ineffective.
So the interaction can go both ways.
Precisely. Consequently, combinations of certain drugs with azole antifungal medications may be absolutely contraindicated due to the risk of serious adverse events, like dangerous heart rhythms or severe toxicity from the other drug. This complexity really underscores the need for incredibly careful medication reconciliation, thorough knowledge of potential drug interactions, and often therapeutic drug monitoring, checking drug levels in the blood, when prescribing or managing patients on azole antifungals. It's essential to prevent serious harm and ensure the antifungal is actually working.
Okay, let's try to break down the individual azole agents then, keeping those interactions in mind. Starting with ketoconazole, what's its place in therapy today? Is it still used much systemically?
Ketoconazole, which was historically administered orally, has largely been replaced by newer azoles, particularly itraconazole initially, for systemic use. This is mainly due to its less favorable toxicity profile. It carries risks of hepatotoxicity, liver damage, and can cause adrenal insufficiency by interfering with steroid synthesis.
Okay, so significant side effects.
Yes. It remains important, however, for topical use in conditions like tinea versicolor, seborrheic dermatitis, and common dermatophyte infections. Ringworm. You'll often find it in shampoos and creams. Systemically, it's a reference substrate for and a potent inhibitor of CYP3A4, highlighting its significant potential for drug interactions, even more so than some other azoles. Due to its systemic risks, oral preparations are now only available with significant restrictions in many regions, including the U.S. It's really fallen out of favor for systemic treatment, except perhaps in very specific, cost-sensitive situations.
What about itraconazole? How does it compare? And what are its key features? It seemed to replace ketoconazole for a while.
Right. Itraconazole is a triazole, and it offered a key advantage over ketoconazole. It lacks that significant corticosteroid suppression seen with ketoconazole, while retaining most of its pharmacological properties and actually extending the antifungal spectrum. Importantly, unlike the imidazoles, itraconazole has activity against Aspergillus species.
Ah, so it hit molds better.
Yes. While it has now been supplanted by other newer triazoles like voriconazole for the primary treatment of invasive mold infections, it remains an important prophylactic agent. It's particularly used in preventing mold infections in specific patient populations, such as those with chronic granulomatous disease, CGD. Now, its ADME is a bit tricky. Itraconazole is available in various oral forms, tablets, capsules, and a solution formulated with cyclodextrin. Absorption is variable and depends on the formulation and food. The capsule form is best absorbed when taken with food, but the oral solution is actually better absorbed in a fasting state.
That's confusing for patients.
It can be. The tablet formulation is specifically approved only for onychomycosis, nail infections. There's also a newer formulation, SUB-itraconazole, with enhanced GI absorption. Itraconazole is primarily metabolized in the liver and is both a substrate for and a potent inhibitor of CYP3A4. So again, many drug interactions. In the plasma, it's present alongside an approximately equal concentration of a biologically active metabolite, hydroxyitraconazole. Both are highly protein-bound. Critically, neither the drug nor its active metabolite appears in urine or, importantly, in cerebrospinal fluid, CSF.
So not good for brain infections.
Correct. A significant limitation for CNS infections. It has a relatively long half-life, so loading doses are generally recommended when treating deep mycosis to achieve therapeutic levels faster. Therapeutically, itraconazole is often considered the drug of choice for patients with indolent non-meningeal infections caused by the endemic fungi, blastomyces, histoplasma, paracoccidioids, and coccidioids. It's also useful in the therapy of indolent invasive aspergillosis outside the CNS, particularly after the infection has been stabilized with Amphotericin B. It has uses in onychomycosis, sporotrichosis, and is used for long-term maintenance therapy in HIV patients with histoplasmosis. However, it's not recommended for maintenance of cryptococcal meningitis due to relapse rates. The oral solution is effective for thrush, oropharyngeal and esophageal candidiasis, often used if fluconazole fails. Its adverse effects are significant enough that it carries an FDA-boxed warning. This warns about possible serious adverse effects, including QT prolongation, which could lead to dangerous heart rhythms, potential for heart failure due to negative inotropic effects, weakening heart muscle contraction, and those significant drug interactions. Serious hepatotoxicity has also been reported, rarely leading to liver failure and death. Common side effects include GI issues, electrolyte imbalances like hypokalemia, low potassium, and rash. Higher doses are linked to more side effects, including adrenal insufficiency and edema. It's strictly contraindicated during pregnancy.
Okay, so powerful, but needs careful handling and awareness of interactions and side effects.
Definitely. Moving on to fluconazole. This one seems to be very widely used. What are its unique properties and how is it typically employed?
Fluconazole is a fluorinated bistriazole, and it's known particularly for its excellent pharmacokinetic profile, which makes it a highly convenient option in many situations.
Its major advantage is that it's almost completely absorbed from the gastrointestinal tract. Bioavailability is very high.
So oral works just as well as live eye.
Essentially, yes. Plasma concentrations are pretty much the same, whether the drug is given orally or intravenously. And its bioavailability isn't altered by food or gastric acidity, which really simplifies administration compared to itraconazole. Peak plasma concentrations are reliable. Over 90% of the drug is eliminated via renal excretion through the kidneys. Its elimination half-life is a convenient 25 to 30 hours, allowing for once-daily dosing. Fluconazole diffuses readily into various body fluids, including breast milk, sputum, and saliva. And crucially for CNS infections, concentrations in cerebrospinal fluid, CSF, can reach a high proportion, 50% to 90% of the simultaneous values in plasma.
That's excellent CNS penetration.
It is, making it a reliable choice for fungal meningitis, especially cryptococcal meningitis. Because of its primary renal elimination, the dosage interval needs to be adjusted in patients with decreased renal function. That's critical. Therapeutically, fluconazole has a wide range of uses. For candidiasis, it's used for everything from oropharyngeal candidiasis, where 100-200 milligrams daily works well, to uncomplicated vaginal candidiasis, where a single 150 milligram dose is often effective. For candidemia, candida in the bloodstream, in non-immunocompromised patients, it's often used with a loading dose followed by 400 milligrams daily. Current guidelines suggest it's an acceptable alternative to first-line Echinocandin therapy in select candidemia patients, and is recommended as a step-down therapy once the isolate is known to be susceptible. For cryptococcosis, fluconazole is critical. It's used for the consolidation and maintenance phases of therapy for AIDS patients with cryptococcal meningitis, following an initial induction course with Amphotericin B, often with Flucytosine. Doses are typically 400 milligrams daily initially, then reduced to 200 milligrams daily for long-term maintenance.
As we mentioned earlier, recent trials show fluconazole plus flucytosine is a promising all-oral induction option for other mycoses. Fluconazole is the drug of choice for treating coccidioital meningitis due to its good CSF penetration and much lower morbidity compared to intrafactical amphotericin B. It's comparable to itraconazole for other forms of coccidioidomycosis. It serves as an alternative for blastomycosis. However, and this is key, fluconazole has no useful activity against histoplasmosis or sporotrichosis and is not effective in preventing or treating aspergillosis. Critically, fluconazole has no activity in mucormycosis.
So important limitations in its spectrum.
Very important limitations. Dosage ranges from 50 to 400 milligrams daily, sometimes higher for meningitis, with a loading dose often used. Adverse effects are generally milder than itraconazole. Common ones include nausea, headache, skin rash, vomiting, abdominal pain, diarrhea. Reversible hair loss can occur with prolonged high doses. Rare but serious cases of deaths due to hepatic failure or Stevens-Johnson syndrome, a severe skin reaction, have been reported. There are also concerns about birth defects, specifically skeletal and cardiac deformities, with high-dose fluconazole used during pregnancy, so it should generally be avoided, especially in the first trimester. In terms of drug interactions, fluconazole is an inhibitor of CYP3A4 and CYP2C9, though perhaps less potent than itraconazole or ketoconazole. Still, numerous interactions are possible and need to be managed.
Okay, next, voriconazole. How does it compare, especially with its expanded spectrum against molds?
Right, voriconazole is another triazole, structurally similar to fluconazole, but it offers increased activity in vitro and an expanded spectrum against certain challenging fungi, particularly molds like Aspergillus. One notable characteristic is its poor aqueous solubility. Its ADA presents some challenges. Oral administration requires careful timing. High-fat meals significantly reduce its bioavailability, so it should be given either 1 hour before or 1 hour after meals. Oral bioavailability is high, otherwise around 96%. It has a large volume of distribution indicating extensive tissue penetration. Metabolism primarily occurs through CYPs 2C19 and 2C9, with 3A4 playing a more limited role. A critical pharmacokinetic characteristic of voriconazole is its nonlinear metabolism.
Nonlinear, what does that mean practically?
It means that doubling the dose doesn't just double the drug level. It can lead to a much greater, disproportionate increase in systemic drug exposure. This makes precise dosing challenging and means therapeutic drug monitoring, TDM, checking blood levels, is frequently used for voriconazole. Target serum concentrations are generally aimed between 1 and 5 mg to try and maximize efficacy while minimizing adverse events. Genetic polymorphisms, variations in the gene for CYP2C19, can cause up to a 4-fold difference in drug exposure between individuals.
Wow, so the same dose could have very different effects in different people.
Exactly. For instance, about 20% of Asians are homozygous poor metabolizers of CYP2C19, compared with only 2% of whites and African Americans. This significantly impacts individual dosing needs and reinforces the value of TDM. Less than 2% of the parent drug is recovered unchanged in urine. Dose adjustments aren't needed for kidney failure itself, but the intravenous formulation contains sulfobutyl ether cyclodextrin, SBECD, a carrier molecule.
Like we saw with some Ampho B formulations.
Similar idea, different molecule. SBECD is excreted by the kidney, and significant accumulation can occur if kidney function is poor, creatinine clearance less than 50 mmHg. In such cases, oral voriconazole is preferred to avoid potential toxicity from the SBECD carrier. Patients with mild to moderate liver cirrhosis need a dose reduction. Therapeutically, voriconazole made a big impact because it demonstrated superior efficacy compared to conventional Amphotericin B, CAMB, in the primary therapy of invasive aspergillosis. Studies showed better response rates and even superior survival.
That's a huge finding, replacing the gold standard for aspergillus.
It was a landmark study. It's approved for the initial treatment of candidemia and invasive aspergillosis, and also for salvage therapy in patients with difficult-to-treat infections like Pseudoescherichia bovidum, Cephalosporin opiospermum, and Fusarium infections. It seems to penetrate infected brain tissue well. Dosage usually starts with IV loading doses, then maintenance, potentially switching to oral later. Adverse effects. Voriconazole is teratogenic in animals and generally contraindicated in pregnancy. Occasional cases of hepatotoxicity occur, so liver function monitoring is needed. A very characteristic side effect is transient visual disturbances, blurring, color changes, brightness, or auditory hallucinations. These are quite frequent, especially after the first dose, usually at night, particularly with IV administration. They typically diminish with time.
Visual changes, that must be disconcerting for patients.
It can be, yes. Patients should be warned about it. Voriconazole can also prolong the QTc interval on electrocardiogram, a significant concern in patients with other risk factors for Torsades de Pointes, a dangerous heart rhythm. Rash occurs in about 6% of patients. Drug interactions. Voriconazole is metabolized by and significantly inhibits CYPs 2C19, 2C9, and 3A4. This means it has numerous and potentially serious interactions. Co-administration with sirolimus, for example, is contraindicated because voriconazole increases sirolimus levels 11-fold. Dose adjustments are needed for other drugs like omeprazole. Careful review of all medications is essential.
Okay, moving along the newer azoles, what about posaconazole? What does it bring to the table, particularly for challenging mold infections like mucormycosis?
Posaconazole is a synthetic structural analog of itraconazole, and it shares that same broad antifungal spectrum. However, it boasts up to a 4-fold greater activity in vitro against many yeasts and filamentous fungi. Notably, this includes activity against some, but importantly not all, of the agents that cause mucormycosis. These are very difficult fungi to treat, so any activity is significant. Its activity against yeasts in vitro is similar to voriconazole. Its mechanism is the same as other azoles. Inhibition of sterol 14-industrilase, ADME. Posaconazole is available in several formulations: a delayed-release tablet, intravenous formulations, and a flavored oral suspension. The delayed-release tablet and IV formulations offer a significant advantage by providing more consistent bioavailability.
Better absorption than the suspension.
Yes, especially because the bioavailability of the older oral suspension, 40 mg/ml, is significantly enhanced by the concomitant presence of food, particularly high-fat food, making absorption less predictable. The newer formulations overcome this somewhat. The drug has a relatively long half-life, 25-31 hours, a large volume of distribution, and extensive protein binding, 98%. Steady-state concentrations take about 7 to 10 days to reach. Renal impairment doesn't significantly alter plasma concentrations, while hepatic impairment causes only a modest increase. The major metabolic pathway is hepatic UDP glucuronidation, not primarily CYP metabolism, although interactions still occur. Gastric acid improves absorption of the suspension, so drugs that reduce gastric acid, like PPIs or H2 blockers, can decrease posaconazole exposure significantly. Diarrhea can also reduce levels.
So things affecting the gut can really impact levels of the suspension.
They can. Therapeutic uses. Posaconazole is approved for the treatment of oropharyngeal candidiasis, though fluconazole is often preferred first line. Its most important role is likely in prophylaxis against candidiasis and aspergillosis in high-risk patients, those over 13 years old, with prolonged neutropenia or severe graft versus host disease after stem cell transplant. It's also proven in the EU as salvage therapy for aspergillosis and several other infections. A recent trial supports its use as a first-line treatment for invasive aspergillus infections, comparable to voriconazole. And because of its increased activity against the molds that cause mucormycosis, it's become a frequent alternative to Amphotericin B for patients who cannot tolerate Ampho B. Dosage depends on indication and formulation, tablet IV versus suspension, adverse effects. Common adverse effects include nausea, vomiting, diarrhea, abdominal pain, and headache. Although side effects occur frequently, discontinuation due to them is relatively low, suggesting good tolerability overall. Drug interactions. Fluconazole inhibits CYP3A4. This means it can significantly increase the levels of drugs metabolized by CYP3A4, like cyclosporine, tacrolimus levels increased by 121%, sirolimus levels increased by a remarkable 790%, and midazolam. Co-administration with drugs like rifabutin or phenytoin decreases fluconazole levels. Fluconazole can also prolong the QTC interval, so it should not be co-administered with other drugs that are also CYP3A4 substrates and likewise prolong the QTC interval due to the risk of dangerous arrhythmias.
Finally, let's discuss isovuconazole, the newest of this group in the source material. What are its distinguishing features?
Right. Isovuconazole is another newer triazole that's actually administered as a prodrug called isovuconazonium sulfate. The body rapidly converts the prodrug to the active drug, isovuconazole, ADME. A notable advantage is that its intravenous formulation is cyclodextrin-free.
Avoiding that potential kidney toxicity issue we saw with IV voriconazole.
Exactly. It avoids the potential kidney toxicity associated with those cyclodextrin carriers. It is highly bioavailable orally, 98%, and more than 99% protein bound in serum. Administration of the oral form with food can reduce its total exposure, AUC, by about 20%, so ideally taken without food, but the effect is less dramatic than with voriconazole. The active drug, isovuconazole, boasts a very long plasma half-life of approximately 130 hours.
130 hours, that's very long.
Extremely long. This allows for convenient once-daily dosing after an initial loading period. Isovuconazole is primarily eliminated by hepatic metabolism, predominantly by CYP3A4 and CYP3A5. Less than 1% is excreted unchanged in urine, meaning no renal dose adjustments are needed. Therapeutic uses. Isovuconazole exhibits a broad spectrum of activity against most yeast species, including Candida and Cryptococcus. It also shows activity against molds such as Aspergillus species, and importantly, activity against most Mucorales species complex.
So another option for mucormycosis.
Yes, it provides another valuable option. The drug is approved for the treatment of invasive aspergillosis and invasive mucormycosis. Dosage involves a loading phase, typically 200 milligram equivalent every 8 hours for 6 doses, followed by a maintenance dose of 200 milligram equivalent once daily, either IV or orally. Adverse effects. Isovuconazole is generally well tolerated. The most frequently reported adverse effects include gastrointestinal disorders, nausea, vomiting, diarrhea, fever, low potassium, hypokalemia, headache, constipation, and cough. Liver enzyme elevations can occur. Drug interactions. Isovuconazole is both a substrate for and an inhibitor of CYP3A4. Consequently, strong CYP inhibitors like ketoconazole can increase its levels substantially, while strong CYP inducers like rifampin can significantly decrease its levels. It can also increase the levels of other CYP3A4 substrates like midazolam and sirolimus. A very unique characteristic, unlike many other azoles, is that isovuconazole causes a dose-related shortening of the QTC interval.
Shortening, not prolonging.
Correct, shortening. Because of this unusual effect, it is statistically contraindicated in patients with familial short QT syndrome.
Targeting the fungal cell wall, the Echinocandins.
Okay, we've spent a lot of time on drugs targeting the fungal membranes ergosterol, like Amphotericin B in the azoles, and also Flucytosine hitting deoxyRNA synthesis. Now let's turn to the fungal cell wall. This is a structure truly unique to fungi, and the Echinocandins exploit that, right? What are these drugs?
Exactly. The Echinocandins are a relatively newer class, but they've become critically important antifungals. Chemically, they are classified as cyclic lipopeptides, big, complex molecules. 3 Echinocandins are currently approved for clinical use: caspofungin, anidulafungin, and micafungin. While they all act through the same fundamental mechanism targeting the cell wall, they do differ somewhat in their specific pharmacological properties, like metabolism and interactions. Fungi susceptible to Echinocandins primarily include Candida and Aspergillus species, making them vital treatments for many common and serious invasive infections caused by these pathogens.
What's their specific mechanism of action? This is where they really stand out, isn't it? Targeting something completely different from the other classes.
This is where they truly offer a different therapeutic approach, hitting a target the other drugs don't touch. Echinocandins inhibit the synthesis of 1,33-wood-D-glucan. This molecule, glucan, is an essential polysaccharide component of the fungal cell wall. It's absolutely required for maintaining the cell's structural integrity and shape.
Like the rebar in concrete.
That's a good analogy. It provides strength and structure. By blocking the production of this crucial building block, echinocandins effectively cause the fungal cell wall to become weak and unstable, losing its integrity. This leads to osmotic instability and ultimately fungal cell death, especially in yeasts. The FKS1P subunit of the enzyme glucan synthase appears to be the specific molecular target of these drugs.
And because human cells don't have a cell wall, let alone glucan.
Exactly. This mechanism provides excellent selective toxicity. It's a target unique to fungi, which generally translates to fewer side effects compared to drugs hitting targets we share more closely.
So what's their range of activity? And is resistance an issue here too? As it seems to be with almost every antimicrobial class eventually.
Echinocandins exhibit fungicidal activity against Candida species. They directly kill these yeast cells, which is a major advantage for treating severe Candida infections like candidemia. In contrast, they are generally considered fungistatic against Aspergillus species. This means they inhibit fungal growth and cause morphological changes to the filaments. They look damaged under the microscope rather than outright killing the mold cells efficiently.
So kill yeast, inhibit mold. Important difference.
Very important distinction. It's also crucial to note their limitations. Echinocandins do not appear to have clinically useful activity against the dimorphic fungi like Histoplasma capsulatum. They're also not effective against Cryptococcus neoformans, Trichosporon species, Fusarium species, or the agents of mucormycosis.
So powerful against Candida and Aspergillus, but not a broad spectrum solution for everything.
Correct. Their spectrum is more focused than Amphotericin B, but they cover very common and important pathogens. Regarding resistance, yes, unfortunately, it has emerged as a clinical problem for echinocandins, particularly in Candida species like C. glabrata and C. auris. This resistance primarily results from mutations leading to amino acid substitutions in the FKX subunits of glucan synthase, the target enzyme itself. These mutations make the enzyme less susceptible to the drug's inhibitory effect.
So the drug can't bind or inhibit the mutated enzyme as well.
Precisely. Interestingly, unlike the azoles, where efflux pumps are a major resistance mechanism, multi-drug transporters do not appear to play a significant role in echinocandin resistance. It's mainly target site modification. The resistance mutations typically occur in two conserved hotspot regions of the FKS genes. It's also worth noting that some Candida species, like the Candida parapsilosis complex and Candida guillemondiae, inherently display reduced in vitro echinocandin susceptibility compared to other Candida species. This seems due to naturally occurring variations or polymorphisms in their fructese hotspot regions. Species-specific clinical breakpoints for echinocandins have recently been described to help guide treatment decisions based on susceptibility testing.
How do these echinocandins move through the body? Do they have any commonalities in their ADME or their side effect profiles?
While the three echinocandins differ somewhat pharmacokinetically, especially in how they're metabolized, they share several important general characteristics. All of them have extensive protein binding in the plasma, typically over 97%. Critically, all currently available echinocandins lack oral bioavailability. They are poorly absorbed from the gut.
Meaning they had to be given intravenously.
Yes, only available for intravenous administration. This is a drawback for long-term or outpatient therapy compared to some oral azoles. They are unable to penetrate into the cerebrospinal fluid, CSF, in significant amounts.
So like itraconazole, they are not used for CNS fungal infections.
Correct. They lack significant renal clearance, meaning kidney function does not significantly impact their elimination. This simplifies their use in patients with renal impairment, no dose adjustments needed for kidney function itself. Hepatic insufficiency generally has only a slight to modest effect on their plasma drug concentrations, though caspofungin requires adjustment in moderate liver failure, as we'll see. Generally speaking, their adverse effect profile is very favorable. Side effects are minimal and rarely lead to drug discontinuation, making them very well tolerated compared to, say, conventional Amphotericin B. The most common local issue is phlebitis or irritation at the infusion site. Histamine-like effects, such as flushing, have been reported, particularly with rapid infusions. And finally, like many antifungals, all three echinocandins are generally considered contraindicated in pregnancy due to lack of sufficient safety data.
Okay, let's briefly look at the three individual agents. caspofungin, mycofungin, and didulafungin, highlighting maybe their key differentiators or uses.
Sure, first, caspofungin acetate. It was the first echinocandin approved. It's water-soluble, derived from a fungus. Its catabolism, how it's broken down, occurs largely through hydrolysis and N-acetylation, with metabolites excreted in urine and feces. Importantly, mild and moderate hepatic insufficiency can increase the drug's total exposure, AUC.
Meaning the dose needs adjusting in liver problems.
Yes, dose adjustments are necessary in patients with moderate hepatic insufficiency. Therapeutically, caspofungin is approved for the treatment of invasive candidiasis and is considered a first-line agent, along with the others, for initial treatment of candidemia. It's also approved as salvage therapy for patients with invasive aspergillosis who have failed or are intolerant of other drugs like Ampho B or Voriconazole. It's also approved for esophageal candidiasis and for empirical treatment of febrile neutropenia. Dosage involves a loading dose, 70 milligrams, then typically 50 milligrams daily IV, potentially increased to 70 milligrams if needed or if given with rifampin. The dose is reduced to 35 milligrams daily in moderate hepatic failure. In terms of interactions, caspofungin can slightly increase levels of the transplant drug tacrolimus. Cyclosporine slightly increases caspofungin levels. Rifampin, a CYP inducer, can cause a slight reduction in caspofungin levels, hence the potential need for dose increase. Next, mycofungin, also a water-soluble echinocandin derived from a different fungus. It exhibits linear pharmacokinetics, meaning dose changes lead to proportional changes in drug levels, which is predictable. This holds true across all ages, from premature infants to the elderly. Small amounts are metabolized in the liver by various enzymes, but unlike caspofungin, a reduction of the mycofungin dose is not required in moderate hepatic failure.
That simplifies its use a bit.
It does. Mycofungin also shows age-dependent clearance in children, faster clearance in preemies and young children compared to older kids and adults, requiring dose adjustments in pediatric populations. It appears to be a mild inhibitor of CYP3A4, causing modest increases in levels of drugs like nifedipine or sirolimus, but notably has no effect on tacrolimus clearance. Therapeutically, mycofungin is approved for invasive candidiasis and esophageal candidiasis. It's also specifically approved for prophylaxis against fungal infections in hematopoietic stem cell transplant recipients, a very high-risk population where preventing infection is crucial. Dosage is typically 100 milligrams LEIV for treatment, 50 milligrams for prophylaxis, and 150 milligrams for esophageal candidiasis. No loading dose is required. Finally, anidulafungin. This one is actually water-insoluble, extracted from Aspergillus nigilans. What's unique about anidulafungin is its clearance mechanism. It's cleared from the body primarily by slow chemical degradation, breaking down spontaneously in the blood, rather than significant hepatic metabolism or renal excretion of the active drug.
So it doesn't rely heavily on the liver or kidneys to get rid of it?
Correct. This is a major advantage, as it means no dose adjustment is needed for patients with either hepatic or renal failure. This really simplifies its use in complex patients with organ dysfunction. Also, no clinically relevant drug interactions have been observed with drugs likely to be co-administered with anidulafungin, which is another significant benefit in polymedicated patients.
So very few interaction worries and no dose adjustments for liver or kidney issues.
Generally, yes. Therapeutically, anidulafungin is approved for the treatment of candidemia and other forms of candida infections, including intra-abdominal abscess, peritonitis, and esophageal candidiasis. Dosing involves a loading dose, 200 milligrams for invasive, 100 milligrams for esophageal, followed by a daily maintenance dose, 100 milligrams or 50 milligrams, respectively. It's important to note that anidulafungin is not approved for use in children, though the other two currently available echinocandins, caspofungin and mycofungin, are approved and frequently used even in premature infants.
Other key systemic antifungals.
Okay, beyond those major categories, polyenes, azoles, echinocandins, flucytosine, our sources detail some other systemic antifungal agents that play important, often more niche roles. Let's start with Griseofulvin. This is an older drug, isn't it, but still relevant for certain infections.
Yes, Griseofulvin is indeed an older, orally administered fungistatic antifungal agent. It was originally isolated from a mold, Penicillium griseofulvum, and it's practically insoluble in water. Its mechanism of action is quite unique among antifungals. It inhibits microtubule function. By doing so, it disrupts the assembly of the mitotic spindle, which is essential for cell division in fungi.
So it stops the fungus from dividing and multiplying.
Exactly. It ultimately blocks fungal cell division. Its ADME is interesting. Blood levels after oral administration can be quite variable. Absorption seems improved when the drug is taken with a fatty meal. Modern formulations use microsized and ultramicrosized powders to enhance absorption. Griseofulvin has a plasma half-life of about 1 day. Barbiturates are known to decrease its absorption. A fascinating aspect of Griseofulvin's distribution is that it is deposited specifically in keratin precursor cells.
The cells that make hair, skin, and nails.
Precisely. As these cells differentiate, the drug becomes tightly bound to and persists in the newly formed keratin. This provides prolonged resistance to fungal invasion in those structures. This is why the new growth of hair or nails is the first to become free of disease. The fungus-containing keratin is shed and replaced by normal, drug-impregnated tissue. The drug is detectable in the skin's outer layer, the stratum corneum, within hours of taking it orally. Its antifungal activity is fungistatic in vitro for various species of dermatophytes, the fungi that cause ringworm, specifically Microsporium, Epidermophyton, and Trichophyton species. It has no effect on other fungi like Candida or on bacteria. Therapeutic uses. Mycotic diseases of the skin, hair, and nails caused by those dermatophytes respond well to Griseofulvin therapy. For Echinocandins, ringworm of the scalp, in children, Griseofulvin often remains the drug of choice due to its efficacy, safety record, and availability as an oral suspension, which is easier for kids to take. It's also effective for ringworm of the skin, Tinea corporis, Tinea cruis, hands, and beard, caused by susceptible dermatophytes. It's also used for Tinea pedis, athlete's foot, although topical therapy is often sufficient. A key point about Griseofulvin therapy is its long duration. Treatment must be continued until the infected tissue is completely replaced by normal hair, skin, or nails.
How long are we talking?
It can take about 1 month for scalp and hair ringworm, maybe 6 to 9 months for fingernails, and at least a year, sometimes longer, for toenails.
A year?
Yes, it requires real patience. And it's worth noting that newer agents like Echinocandins or Terbinafine are generally much more effective and require shorter treatment courses for onychomycosis, nail infections, adverse effects. The incidence of serious reactions is generally very low. Headache is relatively common, reported in about 15% of patients. Gastrointestinal and nervous system effects can occur. It can augment the effects of alcohol. Hepatotoxicity has been observed. Hematological effects like low white cell counts can occur, so blood monitoring is sometimes advised, especially early in treatment. Skin reactions can happen. Drug interactions. Griseofulvin induces hepatic CYPs. This means it increases the rate of metabolism of other drugs handled by these enzymes, such as the anticoagulant warfarin. The dose of warfarin often needs to be adjusted upwards. It may also reduce the efficacy of low-estrogen oral contraceptive agents, likely through the same mechanism.
And then there's terbinafine, another key systemic agent, which you mentioned is often preferred for nail infections now.
Yes, terbinafine is a synthetic alanylamine, structurally similar to the topical agent naphthafine. Its mechanism of action is crucial and different from Griseofulvin or azoles. It inhibits fungal squalene epoxidase. This is an enzyme very early in the ergosterol biosynthesis pathway. By inhibiting it, terbinafine reduces the overall production of ergosterol, but also causes the accumulation of toxic squalene within the fungal cell.
So it hits the same pathway as ergosterols, but at a different step.
Exactly, much earlier in the pathway, ADME. Terbinafine is well absorbed from the GI tract, but its bioavailability is only about 40% due to significant first-pass metabolism in the liver. A key pharmacokinetic feature is that the drug strongly accumulates in skin, nails, and fat. This lipophilicity is ideal for treating infections in these tissues. The initial half-life is about 12 hours, but this extends dramatically to 200 to 400 hours at steady state because it accumulates and is slowly released from these tissues over time.
So it sticks around for a long time in the target tissues.
It does, which contributes to its efficacy even after the drug course is finished. Terbinafine is not recommended in patients with marked azotemia, severe kidney dysfunction, or significant hepatic failure. Drug interactions include rifampin, which decreases plasma terbinafine concentrations, and cimetidine, which increases them, therapeutic uses. Terbinafine, typically given as one 250 milligram tablet daily for adults, is considered somewhat more effective than itraconazole for nail onychomycosis.
Making it a first-line choice for many.
Often, yes. The duration of treatment varies with the site, but is typically between 6 and 12 weeks for nail infections, much shorter than Griseofulvin. Terbinafine is also effective for the treatment of Tinea capitis, scalp ringworm, and has been used off-label for ringworm elsewhere on the body. Adverse effects. The drug is generally well tolerated. Low incidence of gastrointestinal distress, headache, or rash. However, very rarely, more severe adverse events can occur, including fatal hepatotoxicity, severe neutropenia, low white blood cell count, Stevens-Johnson syndrome, or toxic epidermal necrolysis, severe skin reactions. Liver function tests are often recommended before starting and during therapy. Systemic turbinafine therapy should be postponed until after pregnancy is complete due to potential risks.
Specialized agents for challenging fungi.
Now let's explore agents active against some less common, but still very challenging, fungal pathogens mentioned in the source. Microsporidia and Pneumocystis. These have interesting histories, being reclassified, right?
Yes, these are particularly interesting examples because both were historically thought to be protozoan parasites. But recent reclassification, based primarily on genetic and molecular analysis, places them firmly within the fungal kingdom. This really highlights how our understanding of the microbial world is constantly evolving.
Okay, starting with Microsporidia. What are these organisms and how do we treat the infections they cause?
Microsporidia are spore-forming, unicellular eukaryotic organisms. They are obligate intracellular pathogens, meaning they have to live inside host cells. They can cause several disease syndromes, most commonly chronic diarrhea and wasting, particularly in severely immunocompromised individuals like those with advanced AIDS. For treatment, albendazole, which is actually an antiparasitic drug used for worms, is the treatment of choice for most intestinal and systemic infections with Microsporidia, except Enterocytosine B and Vitiforma corneae. Its mechanism involves inhibiting atubulin polymerization, disrupting key cellular processes in the pathogen. For infections caused by Enterocytosine B, which doesn't respond as well to albendazole, or for ocular infections caused by Encephalidazone species, fumagillin can be used. Fumagillin is an acyclic polyene macrolide produced by the fungus Aspergillus fumigatus. Both fumagillin and its synthetic analog, TNP470, are toxic to Microsporidia in vitro. For intestinal avianisine infection, fumagillin can be used orally. It's also used topically as eye drops to treat keratoconjunctivitis, inflammation of the cornea and conjunctiva, caused by Encephalidazone helm. Adverse effects of fumagillin can include abdominal cramps, nausea, vomiting, and diarrhea. Reversible thrombocytopenia, low platelets, and neutropenia, low neutrophils, have also been reported. It's very important to note, however, that fumagillin is currently not approved for human use in the U.S. Its availability is often through special access programs or clinical trials, limiting its routine use despite its potential efficacy.
Okay, and then there's Pneumocystis jirovecii, formerly known as Pneumocystis carinii. What's its significance, and how is it treated, especially when the first-line drug can't be used?
Right. Pneumocystis jirovecii is another fungus that, until fairly recently, was classified as a protozoan parasite. It is the causative agent of Pneumocystis jirovecii pneumonia, or PJP, which used to be called PCP. PJP is a major cause of morbidity and mortality in immunocompromised individuals, particularly those with AIDS, where it was historically a defining opportunistic infection before effective HIV therapy became widespread. It also affects other immunocompromised hosts, like transplant recipients or those on chronic steroids. Now, the combination antibiotic trimethoprim sulfamethoxazole, TMP-SMX, is universally considered the drug of choice for both the treatment and prevention prophylaxis of PJP. It's highly effective. However, some patients cannot tolerate TMP-SMX due to allergies, especially rash, or bone marrow suppression. In these cases, pentamidine plays a critical role as an alternative agent. Therapy for PJP. Pentamidine as a therapeutic agent for active PJP is generally reserved for two specific indications. Firstly, as a 4 mg/kg single daily intravenous dose for 21 days to treat moderate to severe PJP in individuals who cannot tolerate TMP-SMX and are not candidates for other alternative agents like atovaclone or clindamycin primaquine. Secondly, it can be used as a salvage agent for individuals with PJP who have failed to respond to TMP-SMX. However, it's worth noting that for this salvage indication, pentamidine may actually be less effective than the combination of clindamycin and primacone or possibly atovaclone. Prophylaxis. Pentamidine is also used, perhaps more commonly now, as an aerosol preparation to prevent PJP in at-risk individuals who cannot tolerate oral TMP-SMX prophylaxis. This often includes patients with severe bone marrow suppression who can't tolerate the sulfa drug.
So inhaling it directly into the lungs.
Exactly. For prophylaxis, pentamidine isethionate is typically given monthly as a 300 mg dose delivered via special nebulizer over 30 to 45 minutes. However, aerosolized pentamidine has several disadvantages. It only protects the lungs, failing to treat any potential extrapulmonary sites of pneumocystis infection, which are rare but can occur. It also lacks efficacy against any other potential opportunistic pathogens, unlike TMP-SMX, which has broader coverage. And there's an increased risk for pneumothorax, collapsed lung, associated with its use. More recently, an intravenous dose of pentamidine every 28 days has also been successfully used as PJP prophylaxis, perhaps offering better systemic protection. Adverse effects. Reported adverse effects of inhaled pentamidine include bronchospasm, airway narrowing, in about 15% of patients, requiring pretreatment with a bronchodejection. For parenteral, RIV, or IM pentamidine, adverse effects are more common and can be more severe, especially with rapid injection. These can include injection site irritation and pain, cardiac arrhythmias, severe hypotension, low blood pressure, dangerous hypoglycemia, low blood sugar, sometimes followed by a hyperglycemia, electrolyte abnormalities, and acute pancreatitis. Kidney toxicity can also occur. The FDA specifically warns that administration of pentamidine should be limited to patients in whom pneumocystis is identified or strongly suspected, and treatment should proceed with very careful monitoring for the development of these potentially serious adverse effects.
Topical antifungal agents. First line for superficial infections.
Okay, now let's switch gears completely and talk about topical antifungal agents. For many people listening, this is likely what comes to mind first when thinking about fungal infections. Dealing with something like athlete's foot, jock itch, or ringworm, using creams and powders.
It's exactly. Topical agents are incredibly useful and widely used for treating many superficial fungal infections. These are infections confined to the outermost layers of the skin, the squamous mucosa, like the mouth or vagina, or the cornea of the eye. Common examples include dermatophytosis, that's the general term for ringworm infections like Tinea pedis, Tinea cruis, Tinea corporis, various forms of candidiasis like thrush, vaginal yeast infections, candida skin infections, Tinea versicolor, those patchy skin discolorations, and less common things like Piedra, Tinea nigra, and fungal keratitis, eye infection. When it comes to applying them to the skin, creams or solutions are generally the preferred formulations. Ointments can be inconvenient, greasy, and are often too occlusive, trapping moisture which isn't ideal for skin, particularly if the affected area is already macerated, soggy, fissured, cracked, or located in skin folds, intertriginous lesions like the groin or underarms. Antifungal powders, whether applied by shake containers or aerosols, are typically useful mainly for lesions on the feet, in the groin, and similar intertriginous areas where absorbing moisture is helpful. Now, with only a few exceptions, topical administration of antifungal agents is usually not successful for mycoses of the nails, onychomycosis, and hair, Tinea capitis. These structures are harder for topical drugs to penetrate effectively.
So for nails and scalp, you usually need systemic treatment like Griseofulvin or Terbinafine.
Generally, yes, for significant infections. Topical treatment should also not be used for the treatment of subcutaneous mycosis like sportricosis or chromoblastomycosis. These are deeper infections that require systemic therapy. Regardless of the formulation, penetration of topical drugs into thick, hyperkeratotic, thickened, scaly lesions is often poor. In such cases, physically removing some of that thick, infected keratin, like gentle debridement, or using a keratolytic agent can sometimes be a useful adjunct to enhance topical therapy.
Let's start with the topical versions of the Imidazoles and Triazoles. We talked about these systemically, but they're very common over-the-counter and prescription topicals too.
Absolutely. The imidazoles like clotrimazole, miconazole, ketoconazole, grinazole, and triazoles, like terconazole, are closely related classes of synthetic antifungal agents used very commonly both topically and, as we discussed, systemically for some. Their topical indications include ringworm, all the tinnias, Tinea versicolor, and mucocutaneous candidiasis, skin, mouth, vagina. Resistance to topical imidazoles or triazoles is rare among the fungi that cause ringworm. When selecting one of these agents for topical use, the choice should primarily be based on cost and availability, maybe formulation preference, because in vitro fungal susceptibility testing doesn't consistently correlate well with clinical responses for these topical applications. They generally all work quite well if used correctly. Their mechanism of action, as we discussed previously for the systemic versions, involves the inhibition of 14-estrol demethylase, disrupting ergosterol synthesis in the fungus. Let's look at the main modes of administration for topical azoles. Cutaneous application. Preparations for cutaneous use, creams, lotions, solutions, gels, powders, are highly effective for Tinea corporis, Tinea pedis, Tinea cruis, Tinea versicolor, and cutaneous candidiasis. They should typically be applied twice a day for 3 to 6 weeks, depending on the infection. It's crucial to remember that these cutaneous formulations are not suitable for oral, vaginal, or ocular use. Use the right formulation for the right body site. Vaginal application. Vaginal creams, suppositories, and sometimes tablets are all used for vaginal candidiasis, yeast infections. They are typically applied once a day for 1 to 7 days, depending on the specific product and dose, preferably at bedtime to facilitate retention. These preparations are not useful in trichomoniasis, which is a different type of infection caused by a parasite. Most vaginal creams are administered in 5-gram amounts. Some formulations come in both low and high-dose preparations with shorter treatment durations recommended for the higher doses.
Systemic absorption from the vagina is low, typically 3% to 10%.
Although some imidazoles showed teratogenicity in animal studies at high doses, no adverse effects on the human fetus have been clearly attributed to the vaginal use of imidazoles or triazoles, though caution, especially in the first trimester, is often advised. The most common local side effect is vaginal burning or itching. A male sexual partner may sometimes experience mild penile irritation. Oral use for topical effect. The use of the oral trophage of clotrimazole is properly considered a topical therapy, not systemic. The only indication for this 10 mg troche is oropharyngeal candidiasis, thrush. The antifungal activity is due entirely to the local concentration of the drug dissolving in the mouth. There is no significant systemic absorption or effect. Now, looking at a few individual agents within this topical azole class, clotrimazole. Systemic absorption is minimal from skin, 0.5%, and low from the vagina, 3 to 10%. Fungicidal concentrations remain in the vagina for up to 3 days after a single application. Topical use can occasionally cause local irritation, stinging, redness, peeling, itching. Vaginal use causes mild burning in about 1.6% of patients. Oral troches can cause GI irritation in about 5%.
Therapeutic uses. Clotrimazole is widely available over the counter and by prescription in many forms. 1% creams, lotions, solutions, 1% or 2% vaginal creams, 100 mg, 200 mg, or 500 mg vaginal tablet suppositories, and 10 mg troches. Cure rates for dermatophyte infections are high, 60–100%, as are rates for cutaneous candidiasis, 80–100%. For vulvovaginal candidiasis, cure rates are usually 80% with standard regimens. For example, 7-day 100 mg tablet, 3-day 200 mg tablet, single 500 mg tablet, or 3 to 7 days of cream. Recurrences are common, however. The oral troches, dissolved slowly 5 times daily for 14 days, are effective for thrush in immunocompetent hosts. Voriconazole, another very common topical azole, it readily penetrates the stratum corneum and persists there for more than 4 days after application, giving a sustained effect. Adverse effects from vaginal use occur in about 7%, burning, itching, rarely pelvic cramps or rash. Cutaneous use rarely causes irritation. It's generally considered safe during pregnancy, though first trimester caution is sometimes advised. Therapeutic uses. Voriconazole nitrate is available in many topical forms, 2% creams, ointments, lotions, powders, gels, sprays.
It's also available as vaginal creams, 2%, 4%, and suppositories, 100 mg, 200 mg, 1200 mg for 7-day, 3-day, or single-dose regimens, respectively. Cure rates for tenias exceed 90%. For vulvovaginal candidiasis, cure rates are around 80–95%. It may also work for some candida glabrata infections. Ketoconazole, topical, as mentioned, the imidazole ketoconazole is available topically as a cream, foam, gel, and famously as a shampoo, often 1% or 2%. These formulations are used for common skin dermatophyte infections, for tinea versicolor, and notably for seborrheic dermatitis, dandruff. There are many other topical azoles available, like conazole, luliconazole, terconazole, butoconazole, ketoconazole, oxaconazole, sulconazole, sertaconazole. They are generally similar in efficacy for susceptible infections, with differences mainly in formulation, dosing schedule once versus twice daily, and sometimes specific indications, ragicana sertaconazole specifically marketed for tinea pedis. And as we mentioned, fluconazole. This is a newer azolamine derivative available as a 10% topical solution, specifically approved for the treatment of onychomycosis, particularly toenail infections.
It offers a topical option for a condition usually requiring systemic therapy.
Okay, that covers the azoles. Finally, let's explore some other structurally diverse topical antifungal agents mentioned in the source material. These have different mechanisms or uses.
Right, these agents offer unique mechanisms and uses outside the very large azole class, providing important alternatives. Sclipiroxolamine. This agent has broad-spectrum antifungal activity. It is fungicidal to Candida albicans and common dermatophytes, like Epidermophyton flocosum, Microsporium canis, Trigophyton mentagrophytes, and Trichophyton rubrum. It also inhibits Malassezia furfur, cause of tinea versicolor. Its mechanism is interesting and different. Sclipirox appears to chelate trivalent metal cations, like iron, Ff3+. This inhibits metal-dependent enzymes, like catalases and peroxidases, that fungi need to degrade toxic peroxides within their cells. Effectively, it seems to poison the fungus from the inside by disrupting its handling of oxidative stress.
It's a completely different way of attacking the fungus.
Exactly. After application to the skin, it penetrates well into the epidermis and even hair follicles, but systemic absorption is very low, 1.5%, making it very safe for topical use. It can sometimes cause hypersensitivity reactions. It's available as a 0.77% cream, gel, suspension, and lotion for treating cutaneous candidiasis in various tinnias, corporus, crus, pedis, versicolor. An 8% nail lacquer formulation is specifically available for onychomycosis, providing another topical nail option. Cure rates in skin infections are high, 81–94%. The gel and a 1% shampoo are also used for seborrheic dermatitis. The 8% topical solution, lacquer,
is effective for mild to moderate superficial white onychomycosis. Tolnaftate, we mentioned this one briefly. It's a thiocarbamate. It's effective in treating most cutaneous mycosis caused by dermatophytes, trichophyton, epidermophyton, microsporium, and Melasisia furfur. Crucially, it's ineffective against Candida species. For tinea pedis, the cure rate is about 80%. It's available OTC in 1% concentration as cream, gel, powder, spray, solution, applied twice daily. No toxic or allergic reactions have been reported, making it very well tolerated. Naphthafine and terbinafine, topical. These are both alamines. Like the systemic terbinafine, they work by inhibiting squalene 2,3 epoxidase, a key enzyme in ergosterol biosynthesis, hitting that pathway earlier than the azoles. They have broad-spectrum fungicidal activity in vitro. Naphthafine hydrochloride is available as a 1% or 2% cream or gel, effective for tinea cruris, corporis, and pitties, applied once or twice daily. Topical terbinafine 1% cream or spray, applied once or twice daily, is also effective for these kinetias. Both are less active against Candida species and Melasisia furfur than azoles, but can still be used sometimes for cutaneous candidiasis and tinea versicolor. Both are generally well tolerated, with occasional local irritation. Butanafine. This is a benzylamine derivative, structurally related to the allylamines with the same mechanism of action, inhibiting squalene epoxidase. Its spectrum and clinical use are similar to naphthafine and terbinafine. Tavabarol. This is a distinct oxaborole antifungal. It's available as a 5% topical solution indicated specifically for the topical treatment of onychomycosis of the toenails. Its unique mechanism involves inhibiting fungal leucyl tRNA synthetase, an enzyme crucial for protein synthesis, ultimately leading to fungal cell death by stopping protein production.
Another novel mechanism for topical nail treatment.
Yes, offering different ways to tackle that difficult problem. Nystatin. We should definitely mention nystatin again. It's a polyene macrolide produced by Streptomyces norsai, structurally similar to Amphotericin B and acting through the same mechanism, binding to ergosterol in the fungal cell membrane and disrupting it. The key difference is that nystatin is not absorbed from the gastrointestinal tract, skin, or vagina. Its action is purely local. Because of this, nystatin is useful only for candidiasis. It's applied in preparations intended for cutaneous, creams, ointments, powders, vaginal suppositories, though less common now, or oral administration, suspension, pastilles, for candida infections only. Infections of the nails and hyperkeratinized or crusted skin lesions generally do not respond well to nystatin due to poor penetration. For moist lesions like diaper rash or intertrigo, skin folds, powders are preferred. Creams or ointments are used twice daily. Combinations of nystatin with corticosteroids are also available. Allergic reactions are uncommon. Nystatin suspension, swish and swallow, or swish and spit, is usually effective for oral candidiasis, thrush, in immunocompetent hosts, and is very widely used in neonates and infants for oral thrush. Other than the bitter taste and occasional nausea, adverse effects are uncommon. Undecylenic acid. This is 10-undecanoic acid, an unsaturated fatty acid. It's primarily fungistatic, active against dermatophytes. Available OTC in creams, powders, sprays, soaps, often combined with zinc undeselenate, which adds an astringent effect, used mainly for tinea capitis. However, its efficacy is limited. The clinical cure rate is only about 50%, much lower than modern agents like azoles or alamines. It's no longer used for tinea capitis. Finally, benzoic and salicylic acids. Whitfield ointment. This is a traditional classic preparation. An ointment containing benzoic acid, usually 6%, and salicylic acid, usually 3%. Benzoic acid is fungistatic, while salicylic acid is keratolytic. It helps peel off the outer layer of skin.
So it helps shed the infected skin.
Exactly. The combination aims to inhibit fungal growth and accelerate the removal of infected stratum corneum. It's used mainly in the treatment of tinea pedis. Continuous medication is required for weeks to months. Mild irritation can occur, much less commonly used now, with more effective modern topicals available. Outro.
Wow, what a truly deep dive. We have covered an incredible amount of ground here. Everything from the sheer scale of the fungal kingdom, the growing threat they pose, especially to immunocompromised patients, to the really intricate molecular mechanisms of all these different antifungal drug classes, and then zooming right out to understand their precise clinical applications, their pharmacokinetics, and of course, their potential pitfalls like side effects and resistance.
It's genuinely a testament to how complex and specialized modern medicine, particularly infectious disease pharmacotherapy, has become, understanding those subtle but critical differences between drug classes. Their unique targets, membrane sterols, cell walls, DNA synthesis, protein synthesis, their pharmacokinetic nuances, like absorption, distribution, metabolism, interactions, and their specific adverse effect profiles. That's absolutely crucial for effective and safe treatment. We've seen how a drug like Amphotericin B, while still a powerful gold standard, demands incredibly careful management due to toxicity, and how newer agents like the Echinocandins and the latest generation of azoles offer significantly improved safety profiles or expanded spectra for specific, very challenging infections like aspergillosis or mucormycosis.
And that constant ongoing battle against resistance, the multiple ways fungi evolve to evade these drugs, plus the clever ways drugs are formulated, like liposomes or prodrugs, to improve delivery and reduce toxicity. And even the surprising reclassification of pathogens like Pneumocystis and Microsporidia from parasites to fungi, it all just underlines the incredibly dynamic nature of this field. Hopefully you listening now have a much more comprehensive understanding, digging into the details needed to approach this almost like an elite professional in this area.
It really highlights that even with our advanced medications, the fight against invasive fungal infections remains an ongoing challenge. This is particularly true for those vulnerable, immunocompromised populations where these infections can be devastating. What's truly fascinating here, I think, is that the very differences that make fungi unique, their cell wall, their specific sterols like ergosterol, their distinct metabolic pathways, these are precisely the vulnerabilities we leverage to save lives, even as these adaptable pathogens continue to evolve and find ways to resist our best efforts.
So, what does this incredibly detailed exploration mean for you? Well, perhaps it's a deeper appreciation for the silent, microscopic battles being fought every single day within the human body, and the brilliant, intricate science behind the drugs that help turn the tide in our favor. Maybe it prompts you to think about how these specialized insights into antifungal therapy inform broader approaches in infectious disease management and drug development in general.
And thinking forward, it certainly raises an important question, one to perhaps mull over. As factors like climate change potentially alter fungal ecology and distribution, and as global travel continues to spread pathogens, and as medical advances continue to create larger populations with altered immunity, how might the landscape of fungal infections, and consequently the urgent need for new and innovative antifungal strategies, evolve even further in the coming decades?
A provocative thought indeed. Thank you for joining us on this very deep dive into antifungal pharmacotherapy. Until next time, keep digging for knowledge.